Today's training is on being the most effective educator that you can be as a unit peer leader. There are several objectives in this module. We're going to talk about what makes a good educator. We're going to talk about how to get the most out of training with your peers. We're going to talk about different training ideas that will appeal to different kinds of learners because not all people learn the same way. Great education can help overcome resistance to change, which we all deal with in our facilities. Effective educators empower others to succeed and to achieve things they did not think that they were capable of. So let's take a moment to reflect. Think about a time when you showed up to training or an educational event. Maybe it was a class at work. Maybe it was some required mandatory training. Maybe it was a conference. How did you feel going into that training or that educational event? How are you feeling as you're watching this unit today? Is it something like, oh, I've got to get through this? Are you excited to learn something new? Because everything that you feel as a unit peer leader, that range of emotions is what your learners, your peers that you're going to be then teaching, are going to be bringing to the training as well. And so the goal today is to think about how can we recognize some of those things and how can we design our training and education so that we make it exciting, we make it engaging, and we try to mitigate some of the negative things that may limit how much somebody retains or takes away from the training or the learning event. Are you frustrated that you have to watch this module because you're so busy? Are you excited to learn new things, to be a better unit peer leader? Are you concerned that this will just be one more thing that you have to learn to add to your already hectic schedule? Do you want to make a difference? Most people who step up to this role as a unit peer leader, it's because you really feel strongly about safety, that you want to make a difference for your co-workers, and it truly is a role that does make a difference. It's a role that you can feel really, really good about. And hopefully with some of the tools and strategies through this training and education, you're able to improve your effectiveness as a unit peer leader, which again, when we're good at what we do and we get the results we're looking for, is what makes us feel even better about the job that we're doing. Can't wait to learn a safer way to transfer so that you can help your patients. And so your motives might be patient driven. This last bullet, I know I should learn this, but oh my gosh, I am so tired, especially long shifts, or if the training is at the end of a shift and people are already tired before they even came to the training. So why do people resist change? We talked at the beginning of this about effective educators being able to help overcome resistance to change and improve compliance. Well, fear of the unknown. As educators, we can really get people comfortable so that what was unknown is really now familiar and is comfortable and is not scary. Lack of good information and education. Again, this feeds into the first bullet, that if we're not doing a great job with education, people still fear that they don't feel comfortable with equipment. They're not sure how to use it with a different range of patients. So this all ties together. Loss of security. Again, what might they lose? Many caregivers in healthcare, especially those who have been in healthcare for a long time, their identity as a good nurse, as a great therapist, is often centered around their knowledge, their ability to respond to different situations. When we bring something new in, safe patient handling, lifts, different kinds of slings, that can be challenging for people to learn, and it can threaten that identity for somebody who's really good at what they do. Now they feel like maybe they're a novice, and it's not a comfortable position for people. They don't see a problem with the old way. So we need to do a good job with our education in helping people understand why the old way is problematic. And in the module, what it means to be a unit peer leader, you have a lot of research. You've got the numbers, you've got the strain and stress and pressure numbers to be able to go back and say, we know manual handling is harmful. We care about your back. We care about your shoulder. We want you to be able to do what you do without going home in pain every day. And so that's part of being a great educator, is really helping people understand the why. Fear of loss of power and control, lack of resources. If there aren't enough pieces of equipment, there isn't enough time to really dig in and do the training effectively, people can leave that training, leave those educational sessions, and feel like they really don't know what they need to know to be successful. But then the lifts aren't available or the batteries aren't charged. You'll learn more about that in the equipment module. Bad timing, too many competing priorities. Yes, we have to make time for training and we have to make enough time, but we also need to recognize the timing we choose can be problematic for some people, and to the extent we have control over, we want to try and work with people on our unit to time the training when they are most available mentally, most available physically, to actually take in the new information. Changing habits. This is a tough one. It's hard for all of us to change our habits. And then getting outside of our comfort zone. When we're asking people to do something new, again, this ties into the habits, but it's uncomfortable for all the reasons we talked above. And our job as effective educators is to really work with our peers to make it comfortable, make it familiar, make it easy, make it obvious, make it attractive, help people see that when they make this change, look how much better it feels. Did you feel any less strain on your shoulders or your back? Look how much more secure Mr. Smith is or Mrs. Jones is. Really point out those advantages so that people feel empowered and they feel that immediate positive feedback from the change that they have enacted. So some of the steps: timing, think about what else is going on; receptiveness and readiness to learn; belief and confidence in success. Do you believe, as a unit peer leader, that this equipment is going to be useful, easy to use, accessible, and is not going to create more difficulties for the people on your unit that you're training on it? If you're not there yet as an educator, I strongly recommend that you go back to your facility coordinator, go back to your monthly meetings, pull out the equipment, get yourself really confident in it, because it's hard to sell it to others who are maybe a little resistant if you, as the unit peer leader, are not 100% confident in it. Helping people become confident, not just competent. Different learning styles, suggested activity for each type. We're going to talk about this a little bit more. Retaining skill levels after training has occurred. So we've all been there where people have been through the training, but they have this training amnesia. You've probably, if you've been a unit peer leader for any length of time, you've heard this. Yeah, I attended the training, but I forgot. So what can we do to make sure people remember after the training has occurred? We know that the keys to success with safe patient handling and mobility programs are accountability and excellent education. One without the other doesn't work. Even if the best education is in place, if staff are not held accountable for the new behavior, they will not change. And equally, if we try to hold people accountable and we have not adequately educated, it's setting people up for failure. So we want to have both elements in place for success with the program. So what are some of the educational modes we currently use? Equipment fairs. What makes them effective versus ineffective? As you bring equipment in, make sure that people know what they are being asked to grade it on. Have evaluation forms ready. We want you to compare 3 different lifts and tell us which one is easiest to figure out, which one is easiest to attach the sling to, which lift will do the most different things So that if storage is an issue, if one lift will do 2 or 3 things instead of having 3 different lifts, does that make sense? Or is it better to have the 3 different ones? As your peers better understand how the equipment works with all their patients, sometimes what worked when they were a novice learner and they were just being introduced to the equipment is less effective than another piece of equipment as they really get good at using it. For example, if you have a powered stand aid, that one with the foot plate that comes off and one that the foot plate does not come off. When you first do an equipment fair with new learners, people who are not familiar with safe patient handling mobility equipment, they may choose the powered stand aid that the foot plate does not come off because it seems easier to use and it's less complicated. However, as they get more comfortable, as they get more confident in that safe patient handling and mobility program, they may come back 2 months later and say, man, I wish we'd got that lift where the foot plate comes off, because now that I know it, it's really not as complicated as I thought. And if a foot plate comes off, I can do sit to stand and I can walk with that lift. So this is what I mean about really looking at equipment fairs and where are the learners at in terms of their understanding of equipment, and making sure that you have the right equipment for the new learner, but also understanding as they get more confident that their needs may change. New hire orientation, annual training. So most people have at least minimal training in new hire and annual training, but make sure you have enough time allocated for it. Remember, as educators, we want to make sure and we want to empower our peers, not just to feel barely competent and check a box that they have done a return demonstration, but we want them to feel confident. We want them to feel more secure, more familiar with that equipment. So annual training, equipment fairs, new hire orientation are great, but we must follow that up with just-in-time training, mentorship on the units, going to those people who have gone through the training maybe a week ago and saying, let me come with you in the course of your daily care, and let's look at applying what you've learned in real time with the patients that you're working with. If you're finding that it's a struggle to get buy-in from your managers for the time for this, you can come back to this module. You can look at the what it means to be a unit peer leader module and make that strong case to your nurse managers, to your unit managers, to say, this is a really, really important part of my role, and I would like to have this much time, an afternoon, to just walk side by side, help in daily care with my other peers, so that we can all be the safest that we can be. And we do use scripting as educators. We can say to our unit managers or our department managers, my number one concern as a unit peer leader is the safety of my peers and of the patients that they are caring for. Every facility in the country is talking about safety, and it is the number one priority. So what you're doing by asking for this time is you are putting the talk of safety into the walk of safety. Your actions are showing that you care about safety. And that kind of scripting really can make a difference in terms of getting you the time that you need to do these activities. Are annual in-services or new equipment in services mandatory? If we want everybody on the unit to know a piece of equipment, the in-services should absolutely be mandatory for every employee on the unit. If you're just looking at one piece of equipment, half an hour might be enough. If you're looking at 7 or 8 different pieces of equipment and slings and when to use them, half an hour is not going to cut it. You're going to need at least 2 hours. And then what kind of additional time for training and reinforcement on the unit? When you do checkoffs, think about, what do those mean? And are people really competent if they check off a return demonstration? as an educator, we want to be sure that when somebody checks that off, they can personally attest to say, I am confident in my ability to use this particular lift with the patients that I would see on my unit, from simple patients up to some of the more complex presentations that we see. What does your annual competency look like? I would recommend every unit peer leader go back and look at what your unit-based competencies look like and ask yourself, when I check this off and complete it, what level are people at? Are they at the very basic novice, the new driver? First training is that driver's training. I know how to use the equipment, I know what the buttons do, but I don't know what to do if the patient's in pain, if the patient's too big for this sling, if the patient doesn't want to use that, if the patient's in a knee immobilizer. All those extra complexities that make it a little bit more challenging, that critical thinking. We want to be sure that we get people to that comfort level. And if your annual competency just says we've been through driver's training, that's okay, but you know that you need to do more work with those folks. And then what kind of follow-up occurs after initial training? So what about communication and learning? The person receiving the information is the expert on the impact of the communication. So, for example, I may think that I've given you the best instructions on using a piece of equipment, but you may come back to me and say, Margaret, I don't understand. You use too many big words. Okay, you're talking about the sling, but I'm still on the buttons here. When we are educating, we know what we're trying to explain, but we want to make sure that the person receiving the information understood it as we intended them to understand it. So how did I receive the information? How did it impact me? What expectations did I have as a learner? And can I see how this is relevant and valuable to me? The person delivering the information, you as a unit peer leader, you control the intent of the message itself, and it's our job as educators to take an extra step to make sure that what we have intended to teach has in fact been learned. And then crucial conversations to align the message with the receiver's WIFM. And that's the what's in it for me, right? Why would I care to listen to the training that you are delivering today? Does this fit with my workflow? And it's our job as educators to share the relevance, to impart the knowledge that makes their jobs easier, that makes it safer, that helps them care for that 400-pound patient the same as they would care for a 100-pound patient. So let's talk a little bit about the science of learning. There are 3 domains. The affective, we've talked about this quite a lot already. Why do I want to or should I learn something new? And then there's the cognitive piece. What is it that I need to learn? The how, the what knowledge is needed? What are the facts? What are the components? What do I need to know to be successful? And then lastly, this is particularly important with safe patient handling and mobility equipment. How do I actually apply my knowledge? What do I do with my hands? Where do the slings go? What buttons do what? We know that when people attend a lecture, they will retain about 5% of what they learn. And you'll see the reference down here below. When we read something, we do the reading. We don't just listen to it. We will retain about 10%. When there are really good audio visuals, we will retain about 20%. And when there's demonstrations, we will retain about 30%. You will see that the 4 top levels are passive teaching methods. The 3 foundational elements at the bottom of the pyramid are participatory teaching methods. Group discussions, we will retain about 50%. Practice by doing, we retain about 75%. And if we teach others, we will remember about 90% of what we teach. So again, pushing yourself to teach more will help you remember more about the topics you're teaching on. The next step we're going to talk about is readiness for learning. There's pre-contemplation. I'm unaware that there's even a problem. And then there's contemplation. I'm aware of the problem and of the desired change. I may not be taking any action yet, but I know the issue exists. Preparation. I intend to take action. At this point, I know the problem exists and I'm thinking about doing something about it. I may be delaying it, but I'm prepared to. And then there's action, and then there's maintenance. So let's look at each of these levels. Pre-contemplative. I have no problem with the way I move patients. Thanks, but no thanks. This is the person who doesn't want to hear about it, who doesn't come to training, who doesn't show up, or maybe they show up, but they're disengaged. They won't work with the teams. So this is a person who is in pre-contemplative readiness mode. Some of the strategies that you can use are on a scale of 1 to 10. How likely would you be to even give this a try? So engage that person with a question about their unwillingness by asking them, how likely would you be to give it a try? Now, if they say a 1, when you come to it and say, can you give me one thing that you think might be an advantage to using safe patient handling and mobility over manually lifting a patient? Can you think of one benefit? What do you think it would take you to move to a 5 or a 2? Somebody might say to you, I don't think I could even consider it. I'm way too busy. They have told you what their barrier is. Tell me what you don't like about it. They will probably say to you, it takes too much time. It's stored too far away. When you probe a little bit more to try and understand, you can usually find a way to move forward. If I could work with the unit manager to protect some time, would you be at least willing to give it a try? Right? So there's some scripting that you can do to move that person into the contemplative level. I know lifting and moving patients is a problem. My back hurts every day, but I've just learned to live with it. I know I should probably move my patients more, but there are never enough people and I can't lift them by myself. They're telling you they are aware of the problem. They're not yet ready to act on it and really get excited about safe patient handling, but at least they're aware of the problem. What if I could show you a way to do this that's easier? Maybe it's a way that takes less time than doing it manually. Do you think learning the equipment could help you to help your patients move without always having to wait for a third person? And then moving people from the contemplative into preparatory. I need to work with my manager to free up some time so I can come and learn it. This is somebody saying, I'm prepared to, I understand there's a problem, I want to learn it, but let me see if I can work with my manager. Let me start solving some problems so that I can act and I can take part in this. So some strategies to move to action is follow up with those ideas with your peers. If they've given you an idea, help them be successful with implementing it. Go to the unit manager, to the unit-based educator. Let's see if we can make that happen. That is going to empower them to feel successful, to feel like you care, and to understand and trust that this is something they can be successful with. And this is all part of being an effective educator, is hearing what your co-workers are saying to you, hearing the barriers and helping them overcome the barriers. Talk with your unit manager. Try and implement the ideas that your peers are coming up with, or discuss possible alternatives. And now we're looking at action. The person shows up for training, they come, they practice with the equipment, now they are in the action phase. We want to determine proficiency level and help grade the teaching accordingly. We're going to talk about that in a moment. And design training opportunities to have multiple exposures, not just once, but as many times as we can get to, so that people feel familiar and comfortable with the equipment. Remember, we want to move from fear of loss, fear of insecurity, fear of looking like an idiot, all of those fears, we want to move to comfort, familiarity, and confidence. Design a training plan that moves them from novice to experienced and potentially to mastery of the skill. Not all people will want to achieve mastery, but at least to experience, proficient, and confident. And then the last phase is maintenance, keeping people at that level of competency that they really feel that they can continue to be somewhat more independent in their own learning and teaching. And then ensure regular audits and checkups to make sure people are still using the equipment, or perhaps they're giving you feedback about new equipment. So we look at self-efficacy. Self-efficacy is the belief that I have the skills and knowledge to be successful at something. In this case, safe patient handling and mobility. Mastery is the actual succeeding in the task or behavior under consideration. And self-efficacy is an important first step in becoming an effective learner and teacher educator. So believing in yourself, believing you can be a good educator, believing that you can transfer your knowledge and skills to the peers on your unit and be successful with that. And then lastly, believing and having confidence that when you do this, it's going to make a difference to their injuries and to the patient's outcomes. How do we do that? There are several ways that we, and this is not just safe patient handling, this is all behavior, all skills, all new knowledge and activities. We model or encode the behavior observed in those we respect. So this is looking to role models. And we all know who are the people that we have as role models. Look at how they use safe patient handling equipment. Look at some of your national experts within the VA, some of your well-known facility coordinators, the people putting on your conferences. The flip side of that is, as an educator, if you are a respected peer, people are going to watch you. Do you practice what you preach? If somebody is using equipment and they get even just a pat on the back, hey, great job doing that. Look at how much safer you kept your patient and yourself. That is a reward that is positive in the direction of safe patient handling and mobility. It reinforces the behaviors. As we get better at using equipment and get better at a new skill, the way we learn changes. So as a novice, and we're new to the task, we know little or nothing, we are at the show me how stage. Structured training and programmatic curricula are appropriate methods at this point. So if I am brand new, don't send me to an ICU and ask me to figure it out on my own. I'm going to need to see, show me how. Give me little bits at a time, make it very structured for me. As I become more competent, I'm going to demonstrate basic standard. I still need more practice, and I may be at the help me do it better stage. I've got the basics down, but the nuances of things, the applied situations, I'm going to need a little bit more help with. And as I get better, as I apply my knowledge and I do it in an increasingly complex way with more and more patients, I gain experience. I'm going to apply my skills in more complex environments, and I'm going to get better at doing it. At this point, I want to be pointed in the direction of more resources to further challenge me and improve my skills, improve my complexity, help me think outside the box for some of the high risk scenarios and some of the really complex things that are more difficult. And then the master expert come up with new and better ways to do the job, and I can now teach others. Experts and masters can help create the learning activities in a collaborative problem-solving ways. So hopefully we see that depending on where people are at in their learning, the activities we may choose might be different. We want to tailor the experiences to promote learning at all levels. Offer a variety of learning experiences. This will help appeal to all your different kinds and levels of learners on your unit. For example, hands-on group work activities. Some people learn best by talking through things, by reading articles, by stronger cognitive focus, comparing notes, You can use games to enhance learning, make mini contests, set up different things that people can engage in, whether it's the affective, the cognitive, or the psychomotor domain. Set up activities that people can work independently and practice, and then come back as a group and share their experiences. Use brainstorming and participatory problem solving that can be done individually or in groups with peers and with real patients in real time. So again, you can tailor your learning experiences for your peers according to whether people are brand new to safe patient handling or whether they are masters and experts, and whether they prefer more individual types of learning or whether they just love to work in a group. Because again, you have introverts and extroverts who learn differently. Provide feedback to your peers, encourage them, motivate them. Ask them, how do you learn best? As a unit peer leader, you can really be an effective educator by taking a little bit of time to ask your peers how they learn best. Offer a variety of learning experiences by providing clinical scenarios to experiment in a safe environment, such as a simulation lab. Set up different sim times that people can go and play. Provide written, video, and interactive experiences for your peers to choose from. Give them options according to their individual learning style. And then provide evidence and data to show your peers how using SPHM equipment makes a difference to injuries for staff and patients, because some people will want the data, they'll want the research. Make learning fun, right? Who says we can't laugh and have a good time while we are learning equipment? You see here, there's some therapy applications. Make the learning relevant to the group of people that you are teaching as well. If it's nurses, we're learning equipment one way. If it's physical therapists, it's another way. If it's occupational therapists, it might be another way. So again, tailor it, make it fun, have a good time doing it. Plan a fall recovery drill that's unannounced on your unit. This has been one of the most effective things that I have seen done, because it really tests people's ability to respond the way they've been trained. And as a unit peer leader, it tells you where the gaps are. Doing these sudden drills is a really good way for you to identify who needs more help. And then work with other unit peer leaders on other units. Help one another. Share the load. Brainstorm together. Set aside time to mentor new staff and use near misses to identify opportunities where further training is needed. So thinking about training opportunities, pre-live preparatory training. What can you do to give people articles to read, videos to watch before they come to the training? New hire orientation, equipment competency. So there's the buttonology, but then there's also the application, patient assessment. And then the what if. What if the patient has a long leg immobilizer? What if they're on spinal precautions? What if they're in the ICU? What if they're high fall risk? What if they're in pain? What if they're 500 pounds, right? All of these things that make it more complex, these are the what ifs that you can apply to your training and your learning scenarios. Real-time application, that mentoring at the bedside is so, so valuable. Looking at high risk, low volume scenarios, things that don't happen very often. Root cause analysis, these can be a great teaching tool when you have a safety huddle after a near miss or an injury. We can use these as teaching and learning tools. Engage others to teach each other. You don't want to be the only educator on your unit. An effective educator engages people in a way that they can then show other people what they've learned. You might take one piece of equipment and say to everybody on your unit, okay, on Thursdays, we're doing 5-minute standing aid training. So once training has been completed, we want to provide positive reinforcement for behavior change, recognize co-workers when they use what they've learned. Yes, we've heard this before, but again, remember, we need to hear things sometimes 5 or 6 times in different ways. It's like, oh yeah, that's something I remember that I want to do. Follow up with feedback about impact of new behavior. Share how their new habits have helped reduce injuries. Continue to reinforce until co-workers have developed new habits. So this is a little exercise that you can do as an educator. It's not mandatory, but many unit peer leaders have done this, where you just do a self-awareness check. Look at your strengths. Look at how you learn best. How do you plan to challenge yourself as an educator? Can you discover your own levels of proficiency and the levels of proficiency in your co-workers? How can you do that? What are some ideas that you can put down and you can immediately apply after watching this module? How can you make training fun? And what are some things that you will take and apply in your teaching on your unit? So in summary, effective training is a key component of successful culture change with any new initiative or ongoing initiative for sustainability. Accountability does not work without sufficient training. Assess your learners, your peers. Figure out how ready they are for change and where they are at with self-efficacy. Check into their learner styles. How do they learn best? Where are they at in the proficiency level? Novice, competent, experienced, or master? Tailor your teaching strategies and your style to the learner level and the learner style and where they're at. Don't stop at basic competency. Aim for mastery. Understanding not everybody will get there, but aim to get those that are prepared to get there. Give them those opportunities. Follow up, provide feedback, and be mindfully aware of successes, and never stop training. So a couple of quick knowledge checks. The 3 domains of learning are A, novice, competent, experienced; B, contemplation, preparation, action; C, affective, cognitive, psychomotor; or D, accommodator, diverger, converger. The answer is C, affective, why; cognitive, what; and psychomotor, how. I need to learn something. Let's do another one. All of the following are reasons people resist change, except which one? Fear of the unknown, thorough education on new skills, lack of resources, or fear of loss of control. And I think that's a fairly easy one. B, thorough education on new skills, because we know that A, C, and D are all reasons why people resist change. Our third knowledge check. Which of the following factors impair learning? A, optimal learning environment; B, making sure there are no distractions; C, high levels of stress in the learner; or D, providing a variety of learning activities. And the right answer for this is C. High levels of stress in the learner will impair their ability to receive and remember the information. Our last knowledge check. Your co-worker is in the contemplative stage of change in their behavior. You know this because when you ask if they will be at your training event, they respond with A, I know safe patient handling is important, but I just don't have the time to come to this training event. B, I don't need that equipment. I've been a nurse for 20 years and I've done just fine. C, let me ask my manager if they can free me up to come to the training event. Or D, I'll be there for sure. Those techniques you shared last month were really, really helpful. Let's unpack this a little bit. B, I don't need that equipment. I've been a nurse for 20 years. This person is telling you they are in pre-contemplative. They don't see a problem. C, let me ask my manager. I'm preparing to be able to come. D, I'll be there for sure. These techniques you shared last month were really helpful. They're already engaged. They're maintaining. So the right answer is A. I know it's important. I see the problem, but I just don't have the time. I can't see how I can get to that preparatory stage. So these few slides are giving you some resources if you want to look up and learn any more about being an effective educator. There's lots of information out there. Congratulations, you have completed the Effective Educator module. Thank you for your service as a unit peer leader. Your skills as an educator can transform the culture on your unit. And we hope that this has been helpful to you to improve your ability to be successful on your unit. Thank you.